Thank you for joining us. The program will start shortly. Thank you for joining us. The program will start shortly.
Good afternoon and good evening, everybody. My name is Tzvi Marins, and I am moderating this session titled The Israeli and American Doctors on the Front Line, Comparing Global Pandemic Response, and I will introduce our panelists in one moment. I am a past president of Jewish Federation of Northern New Jersey and still involved as chair of the investment committee. And I am, of course, very familiar with the partnership that we've had with Nahariya. The Jewish Agency's partnership together, Peoplehood Platform, has become a paradigm for successfully partnering global Jewish communities directly with Israel communities. P2G connects 450 Jewish and Israeli communities in 46 city-to-city and region-to-region partnerships, engaging more than 350,000 participants each year in meaningful, ongoing connections between Israelis and Jews around the world through their unique programs and one-on-one encounters. Just a very brief history, as when Northern New Jersey was looking for a partnership, we chose Nahariya. And the reason why it was a perfect match for us is because it was mutual. It was good for both groups. We were looking for what would be right for us and what would be right for Nahariya. And there were three aspects of it. One was the educational system in Nahariya and the educational system in Northern New Jersey. Number two was the presence of the Yeshiva Nahar Deah and the very yeshiva-oriented crowd in Northern New Jersey. And finally, there was the medical connection. There are a lot of physicians, a lot of hospitals, and of course, with the hospital in Nahariya. And this is an outshoot of that. We are going to talk today briefly about general issues with coronavirus, and then talk more specifically about Israel response, American response, and the comparison. So I'd like to introduce our panelists. First, we have Dr. Aryeh Eisenman. Dr. Eisenman was born and raised in Haifa. He completed his medical studies in Tel Aviv University. He specialized in internal medicine at Carmel Medical Center in Haifa and served as a senior physician in internal medicine at Rambam Medical Center. He is currently the district physician for Magen David Adom. In 2001, he was appointed head of the internal division of the Department of Emergency Medicine at Galilee Medical Center, a position he held for 17 years. So Dr. Eisenman, welcome, Baruch haba. And we have Taya Glotzer, who is Director of Cardiac Research at Hackensack University Medical Center in Hackensack, New Jersey, and a Professor of Medicine at the Rutgers, New Jersey School of Medicine and the Hackensack Meridian Seton Hall School of Medicine, in addition to being a full-time partner at Electrophysiology Associates. And I am also a pediatric cardiologist, so we have a nice rounded group of people here. So before we begin, אני רוצה לדבר עם כל המשתתפים פה שמדברים עברית יותר טוב מאנגלית. אני רוצה להגיד לכם שלום. אני לא רוצה לשבור את השיניים שלי בעברית, אז אני אספיק פה ולהגיד שאפשר לשאול שאלות בעברית, ותומר נמצא והוא יעשה תרגום בשבילי. Folks, if you have any questions during this, please hit the Q&A button on the bottom of the screen, and we will try to filter some of the questions. Okay, now let's jump in. The first thing I'd like to do is divide this into two parts. One is just a general review of certain more current issues with coronavirus, and then to talk about Israel versus America. So Dr. Eisenman, let's just talk now briefly about what the status of current therapies for coronavirus.
Before I answer this question, I would like to thank few people that I wouldn't feel, comfortable if I don't do that. And I mean all those people who made all this first ever Zoom meeting between New Jersey and Narea possible. And I mean the people in New Jersey, Francie, and of course Melina and yourself, and in Israel Doron, Sharon, and of course Tomer, and Ravit too, and there are many other people who I just don't mention right now. And of course Joshua, who helped us out with all the technical issues. Okay. So now let's go on. What was the question, please?
So
can you repeat the question, please?
The current status of therapies, how we're treating coronavirus.
Okay. So the problem with this virus is that we don't know very much about it. And we learn how to deal with it, along the treatment. And we treat it symptomatically and according to the situation. So throughout a few weeks that have elapsed ever since we heard about this virus, we have learned few things about it. It's a multifaceted virus. It acts on different playgrounds, if I may call it that way. And it has different pathophysiologists. First of all, most of the cases are asymptomatic. They don't even aware of the fact that they are suffering of any kind of disease. And the other might feel that they have some kind of a flu, but they won't even recognize that it has to do anything with coronavirus or the COVID-19. The worst thing is usually the elderly, who are usually risking a very severe disease that are risking their life. And what I mean is two kinds of respiratory disease. One of them is inflammatory, that means pneumonia, and the other one is autoimmune disease of the lungs, which is a real, what we call cytokine storm that's going on in the lung, and we have to take care of that. And recently we have found this like Kawasaki disease of children. You know that until recently we saw that children are not affected very severely by the disease. You must know much better than me about what I'm talking about right now. But this disease that we call it multi-system inflammatory disorder of children, it seems that it is similar to Kawasaki, still different than it is, and it affects the vascular vessels and the mainly vascular vessels of the heart, I mean the coronary arteries. And some people are very, very sick, and they are in fact having something very close to acute coronary insufficiency. And fortunately, most of them are recovering well, but that's an impact that we are having only after very, very difficult ordeal that they are having. Okay, so those are the forms. And how do we treat it? We treat it accordingly, I mean symptomatically. The people who are having just the flu, they are treating as such. And the people who are having a lung disease, those people have to be hospitalized in special intensive care units, and usually they are intubated and ventilated. And we are also trying all kind of anti-inflammatory medication. Some of them are new, some of them are old. You all must have heard about the hydroxychloroquine that right. President Trump is so fond of.
So
we are less fond of it, but we use it. And the children, that is most interesting, they have to be hospitalized in cardiac intensive care unit, exactly like in adults. And they are treating exactly the same way.
Okay, so Dr. Glotzer, tell me about your experience inpatient treatment. Actually, I'd like to specifically talk about what I understand to be the only now proven drug that seems to help is remdesivir, and what are the other medications that are on the horizon in the acute treatment of coronavirus?
Well, so first, I also want to thank the Jewish Federation and Dr. Marins and to get this program together. And it's a pleasure, and it's interesting to see all the messages come out in Hebrew that I can't read at all. The other two things I wanted to say is first, I am a cardiologist specializing in arrhythmias, electrophysiology. I'm not an expert on coronavirus. So whatever I say, please take it with a grain of salt. And finally, I want everybody to know that the heroes in this response are the nurses. And, as I had said earlier, I was redeployed from my cardiology duties to work on the coronavirus floor. I was initially given 3 days in April and then 3 days in May. And fortunately, because people have gotten better, my May days were taken away. But during my April days, I spent about an hour on the wards, seeing 6 or 7 patients. And then I was able to leave and go back somewhere where it was clean, take off my mask, write my notes. And the nurses, even the nurses in my office who see outpatient cardiology patients most of the time, were redeployed to these COVID wards and spent 8 hours a day there wearing their masks and really sacrificing their lives. And so I want to say, kudos to the nurses. In terms of therapy, so, honestly, from April to May, it's changed dramatically. As you just said, I mean, when I was on the ward in April, every single patient got hydroxychloroquine, everybody. And now nobody gets it except President Trump. We are not giving it to anyone because it's been shown not to work. I would say patients who come into the hospital now are sicker. People know now that if they have mild symptoms, they should stay home. And they tend to come in now to the hospital like during the 2nd or 3rd week of their illness. They're quite ill. They have other comorbidities. And the therapy is really supportive care. Now, the therapies that are under investigation are remdesivir, which has been shown to decreased length of stay, but it has not been shown to have an impact on mortality. It's an antiviral agent. There are other antiviral agents, lopinavir and ritonavir, some other one that was just shown in the New England Journal of Medicine not to work, which I think is interesting because they're both antiviral drugs, and remdesivir does seem to have some effect and the others don't. There are these IL-6 inhibitors, which I think work on the inflammatory response, the cytokine response that we were just talking about, and they work on that. And I would also say that I think what's happening in children is the exact same thing that's happening in adults, just without the prior illness. They're having a cytokine inflammatory response, but they're never having the prior illness. And then the other thing that is very interesting, but I don't really know the data, is the convalescent plasma. So taking plasma from patients who've been infected, who have proven antibodies, and giving those to patients. And the problem really with all these therapies is that we are giving them currently to patients who are super ill, like they're intubated. And the bottom line is once you're super critically ill and intubated, your prognosis is so poor that there's not a big effect of these therapies. And I think the best thing to do is to try to give these therapies earlier. And I was telling Dr. Marins earlier, my daughter just graduated medical school at Hofstra on Long Island, and at the hospitals where she worked at North Shore, they're actually giving remdesivir to everybody who comes into the hospital, which I think is the right thing to do.
It's challenging because when you have a major illness like this, everybody's clamoring for the medication, and the only way to prove if something works is to have blinded control studies. That was the big fiasco with the hydroxychloroquine, which was proven to be not effective. And in fact, Taya would know this better than anybody, that there are issues with arrhythmias, and perhaps some of the sudden deaths in these patients was because of the hydroxychloroquine and maybe the azithromycin. Okay, so let's touch briefly about testing, because that still is, and that will segue partially into Israel versus United States. So Dr. Eisenman, what is the, just briefly, the types of testing? I'm specifically referring to the PCR testing, and then I'll have Taya talk about the antibody testing.
Yeah, well, in fact, in Israel, they do both kind of tests. They all started with the PCR test, and it was obvious that in order to know what's going on around and to have a kind of roadmap of the disease, the way it's spread and how many people are affected, you had to do as many tests as you can. And what we were using is the PCR testing. At the beginning, it was only one laboratory, the one of the Ministry of Health, which is in Tel HaShomer in Ramat Gan, next to Tel Aviv. And the people who were doing it were, in fact, it was the Magen David Adom. That was my job to monitor this kind of testing. The people of Magen David Adom were appointed to go home to the homes of those people who were suspected of having COVID-19 and take samples. So the question was how many samples you have to take in order to get a large picture of the disease. And it seems that you have to get as many samples as you can. And so at the beginning, we started with some hundred, and then we moved into some thousands, and finally we reached over 10,000 tests a day. And this is quite a lot, quite impressive. Okay.
So
now,
wait, let me,
that,
I want to
yes.
just, because I want to hold on to that when we start comparing. So just Taya, just tell us quickly about the antibody status, and then we're going to go to the Israeli response versus the American response.
Sure. So, I mean, there is currently an antibody test available. I don't think anybody is certain how accurate it is. Certainly there are false negatives, I think. People who have no antibody, the test says they have none, but maybe they do have some. I know for healthcare providers, it's now almost mandatory, like everybody is going to be antibody tested. And I don't know exactly how available it is for the public, but I think a doctor can write a prescription and you can get an antibody test.
Okay. All right. So, you know, the intriguing part of all of this is that anybody who looks at the data sees that the total number of cases in Israel are relatively low. Israel has virtually eradicated the disease from its population. And the mortality rate, I just looked at the numbers today, it's something on the order of 1 to 1.5%. The numbers are varying, and if you look in the United States, it's much higher, and it's certainly in the Northeast, where we're from, it's very, very high. We're certainly at the epicenter of the epicenter. So the intriguing component here is what was different about what is going on and what has been going on in Israel versus the United States to account for that. And of course, you know, it would be very easy, and then we can close this conversation by saying there's a pasuk that says Tamid Einei Hashem Elokecha Ba Mereshita Shana Ad Acharita Shana, that Israel is very, very special, and that God is there 24 hours a day, 365 days a year, and not elsewhere. But I suspect that some of the more rational scientific people are not going to be satisfied with that. So first, you know, Aryeh, first tell me what your sense is, not about what was done, but what is it about the demographics in Israel that the mortality rate seems to be less? And then we'll talk about the process and the procedure.
Okay, so you know that everybody knows that the society in Israel is divided into clusters. We have a kind of tribal structure in Israel. And that's why we have in Israel, I would say, red communities and green communities. Red communities are those societies in which you have a very high density of cases, and the green society, those are the societies in which you almost don't have any cases. I can give you some examples. Everybody knows Israel, right? So among, for instance, the Orthodox Jews, for instance, or some of the Arab villages, you have a very high density of cases. And there are some reasons, if you want me to specify on that, I may. And on the other part, places like Haifa, for instance, or Nahariya even, have very low morbidity of COVID-19. So you may ask what the reason is. So there are two reasons. One of the reasons, it's the way they live. For instance, in Bnei Brak, which is very high density of COVID-19 relatively to Israel, people are living in small apartments, very large families with many members in each family, and very close to each other. So even if you go through the streets of Bnei Brak, the risk you are having to encounter somebody who is having COVID-19, who is affected by COVID-19, is very high because it's very crowded over there. On the other hand, if you go to a kibbutz in Israel, or you go to Nahariya, or you go to Haifa, the situation is much better. People are socially living in a larger apartment. They have fewer members in each family, and they have, well, I don't know if I'm allowed to say that, but they have better hygiene procedures. And so they have, that's why they are called the green areas.
Okay, so let me interrupt for a second. So Dr. Glotzer, you hear what he's saying, and yet I live in northern New Jersey. I understand New York City, that might hold, but I live in northern New Jersey, as you do, and we had a very high density of cases in our area that I think was not because of those reasons. So do you have any insights about that, Dr. Glotzer?
Well, I mean, I think it is partly those same reasons. I do think there's plenty of areas in northern New Jersey, Hoboken, Fort Lee, where it is more crowded and there are more people living together. And I would say in the New York area, I mean, Queens was the worst community, and that is very densely populated. But I also think we took too long to heed advice. We took too long for the shutdown to happen, and we took too long to socially distance and wear masks and behave properly. And I would blame the government for that. I mean, they didn't take it seriously soon enough. And most of the people who got sick, certainly the, I would say the healthy people, like healthcare workers who got sick at the beginning. And they got sick at the beginning because the emergency room was full of people with COVID-19 and nobody was even wearing masks. I mean, I remember walking through the Hackensack emergency room early on, I don't remember exactly what month it was, seeing one of my ER physician colleagues and saying to him, "Why aren't you wearing a mask? Aren't you afraid?" And he was like, "Oh, whatever." And like 6 weeks later, I saw him in the hall and he said to me, "You called it, you called it." He had no idea this onslaught was coming. And so I think a lot of healthcare workers and physicians got sick early on because they were just exposed. And so I would say people were exposed. The reason in northern New Jersey is lots of people were exposed because they didn't protect themselves soon enough.
So Aryeh, do you think that is the Israeli response was more rapid and avoided the large upslope in the curve, or was it the response that was very effective in Israel?
Okay, so I don't think, I know, and as a matter of fact, that was the case. In fact, the reason that we ended this corona, hopefully we ended it with a relatively low number of casualties, is because the government and the Ministry of Health reacted promptly. In fact, immediately. And without any hesitation. And I really should bless them for that. As soon as we heard about the disease, in fact, everybody heard about the disease still when it started in China, and we were shocked by what was going on there, and we followed it very carefully. But as soon as we traced the first case in Israel, we, on the same 24 hours, we closed the borders. We didn't let anybody in unless he could prove that he is healthy. And all the others were confined immediately. Were locked. They were quarantined in special places, first in hospital, and later on, when the number just increased, we put them in hotels and motels and whatever we could find a place. And then we appointed a special unit in the division in the army, the Home Front Command, to take care of them, because they are like the FEMA in the States. They know the best how they should take care of those people. And I can assure you that nobody that was put in such an hotel could escape out. And until if he ended up 14 complete days over there and made sure that he didn't have the disease. And I think those measures, these quick measures, together with the samples, that's what saved us.
Okay, Taya, do you think that that's a correct assessment vis-a-vis what we failed to do here in this country?
Yeah, 100%. I mean, I know it's still true. We have a nephrologist at our hospital who works here 2 weeks a month and travels to Israel 2 weeks a month. And I saw him a few days ago. He's going back to Israel. He's going to have to be quarantined for 2 weeks before he can go out. And we're not doing that at all. I mean, people are traveling. COVID-19 took more lives in America in 1 month than the Vietnam War took over 8 years. It's terrible. And people don't believe it, including our leadership at the beginning. And so we just didn't shut down in time.
Right. So, I've tried to, think about this in terms of categories. And I think that there are so many aspects of this. One is that what makes our America a great country, which is the heterogeneity and the diffuseness of leadership. You have the federal government, you have state governments, you have local governments, which often works very well for us, work very, very much against us in this regard. Israel has very centralized leadership. I think the medical system is more centralized as well. And they were able to put that down. Number two is that they were able to, as you mentioned, to close down the country completely. It's a much easier country to close down. One big airport, then the borders are already closed down. And then I think also there's some sort of practiced pattern that Israelis have. Israelis are used to, they're very independent Israelis, but when it comes time to emergencies, they're practiced in emergencies. There's a war, there's a terrorism, there's bombs. And so this was yet another emergency where everybody was arevim ze bazeh. Everybody had to do it for everybody else. And we have not yet done that here.
Right. I want to say one more thing about that. I mean, our son lives in California. California did such a better job than New York, such a better job. I mean, they have way fewer cases and they shut down and the government, I mean, he and his friends were driving in Los Angeles. They got a ticket for $1,500 for not his friends, he wasn't there, for driving 4 people in a car. I mean, that doesn't happen in the New York area. So I would commend California because they're just as densely populated, although a little more spread out. But they did a much, much, much better job of containing than New York.
So in just to conclude, so Aryeh, you mentioned that you hope it's eradicated. There's a hope in Israel that it will stay flat. There's very little hope in this country that this is the end of the epidemic. It's very clear that there's going to be another wave as things start to loosen up. And of course, we hope Israel will be all over it so that if there is a bump in cases, they'll be able to restart the controls that they've had. And it's admirable what has been done in Israel, and less than admirable how we have approached this here in this country. So I would like to, I think we could talk about this for hours. We want to really keep it down to the half an hour that we promised. First thing I want to do is I would like to thank, as was done earlier, Melly for putting this together and the whole group here, and of course Tomer in Israel, and both groups. It's just an amazing opportunity for all of us to be together, to really feel Am Echad Ki Ish Echad, like one nation, one person. We all care about each other. Now is the time for the Israelis to really care about us. And
find a vaccine for us, please.
And the vaccine is starting.
We're counting on Israel to find it.
Exactly, and we're hopeful that
it already did.
Well, it's exactly right. So we're hopeful that we didn't even have a chance to talk about the vaccine, but we're hopeful that it will happen more. So really, thank you all for joining us. I miss being in Israel. My wife and I usually come to Israel during this time of year for Yom Ha'atzmaut and Yom Yerushalayim, and we couldn't, and we miss it. So mitgagim lachem, we miss you. I thank especially now, of course, our 2 panelists, Professor Dr. Eisenman, thank you so much, and thank you for all that you do to keep Israel safe. And Dr. Glotzer, one of my colleagues here in the northern New Jersey, thank you for everything you do medically and also in your volunteer work. So thank you, and everybody should stay safe and healthy.
Wish you all the best.
Thank you.